Okay, great. Welcome to the AES Professor's Rounds Adult Case Studies. My name is Jill Hunt, Education Coordinator for the AES. Before we get started, I have a few housekeeping notes. This is a 1-hour interactive session and we encourage your participation. I will unmute your microphone so you have control of your mic. If you are not speaking, please keep your mic muted. You can also use the chat function for questions or comments. Click on the chat icon in your control panel. A recording of this case conference will be made available on the training continuity section of the AES COVID-19 Resource Library. Your professor today is Dr. Mike Sperling, Baldwin Keys Professor of Neurology at the Jefferson Comprehensive Epilepsy Center at Thomas Jefferson University. Welcome, Dr. Sperling.
Thanks very much, Jill. Welcome to everyone. We'll have more people joining. Jill, you have given me, so I have access to the poll, so that's perfect. So we're going to run through some different cases today. There'll be a mix of cases, discussions. I'll show some videos. I've got some EEG questions for you as well. And I'd like this to be interactive, so we have two ways of being interactive. One is through the chat function, and I see Jay Bronder says it's raining in Baltimore too, so that's good. And the other is unmute yourself and ask a question and say something. Please feel free to interrupt. Okay? So let's start with the first case. So case one, this is a 76-year-old man who's in good health, active. 2 months ago, he began to experience paroxysmal symptoms. His left index finger begins to twitch rhythmically for about 20 seconds. At times, it spreads to involve all the fingers, and he gets a sense that the left side of his mouth is a little tense also. And then it ends in 20 seconds and he's fine. There are no other symptoms. He feels normal when it ends. Nothing else has happened. His speech is normal. He can talk with it. His wife was with him on one occasion. And he says to us that it started 2 months ago and he's had 3 attacks. The last one was about a week and a half ago. They've typically happened in the afternoon or the evening. And he says that otherwise he's fine. He has really no significant active medical problems. He's remarkable. He's a 76-year-old man who doesn't take medicines. He doesn't require medication. He's got no risk factors for brain disease of any kind, and he's got a normal neurological examination. His MRI shows the expected few little white spots on FLAIR and T1 imaging, mild small vessel ischemic disease, but it's really quite minimal. So I think the first question we'll put to you is, what is your diagnosis? And we'll do this 2 ways. For those who've been on these before, you'll recognize it. We're going to have a choice of questions, and you'll just answer the question in the poll, and then we can speak as well. But what are your choices for differential diagnosis here? Is this a focal seizure? Is it a paroxysmal dyskinesia? Is it a psychogenic seizure? Or is this the first sign of Creutzfeldt-Jakob disease? We'll see how many votes we have and who we have. So I think we're actually lucky today in that we don't have a huge number of participants. In the past, we've had 70 or over 80 people with us, not all of whom voted. Now it looks like we're in the neighborhood of 20 people total. Okay, so everybody votes. I'm going to close the voting now. Somebody voted twice, it looks like. So I'll end the polling and share the results so you can see that almost everybody said it was focal seizure, and one person said it was a focal seizure and paroxysmal dyskinesia. So, would a paroxysmal dyskinesia be so stereotyped and happen in such a fashion with a sense of spread? So one finger twitches and then spreads to the others, and the tensing in the side of the face? No, that's really a classic Jacksonian march. And I think that we would say that this is clinically a seizure. And that's all you need. Every test can be normal. The diagnosis of epilepsy and seizures is made by virtue of the history. And he's had 3 of them. So yes, it's a seizure. It sounds like a focal motor seizure. And now let me ask the next question. And that is, we want to ask another question. I have to pull up another poll. What do you do with this guy? Should we start treatment? And if so, with what? And your choices are no treatment at all, You could offer him perampanel. I've offered Lamotrigine, gabapentin, carbamazepine, divalproex, and levetiracetam. So there are 5 or 6 anticonvulsants, or do nothing is your choices. What are you going to do with this fellow? And this is basically what you have. He's had his finger twitched 3 times in 2 months, spreading to the hand with a sense of tensing in the face. And there'll be 5 more seconds for you to offer opinions. Only 10 of you have. We have to double the number. What are you going to treat him with? A few more people still haven't voted who offered opinions before. Choose your drug, choose your poison, or none. 2 seconds, 1 second, gone. Okay, done. So this is what we have. You can see, you should all be able to see it. Can everybody see it? You see the poll? Somebody give me a clue.
Yes.
Okay, good, thank you. So, yeah, so 4 people out of 19 said no treatment at all. Nobody voted for perampanel, 2 want Lamotrigine, nobody said gabapentin, 8 said carbamazepine, nobody wanted divalproex, and 5 said levetiracetam. And I assure you, if we had a group of 500 people or 1,000 people from around the world, we would see a fairly broad spread of recommendations in this. So what are your choices? And obviously in one circumstance, we could say, you have a discussion with the patient, is this worth treating? And so let me ask one of you, somebody volunteer, but speak up. Those of you who wanted to treat, why do you want to treat this man? What makes you feel obliged to prescribe a medication for this fellow? This will require somebody actually speaking and unmuting himself or herself. Anybody want to offer an opinion? Why do you think he needs to be treated?
Hey, this is Jay Bronder. I put treatment, but you make a good point. If it's not bothering him in his life, and then maybe there isn't a need to treat. But I guess if it's impacting his life in some negative manner, then maybe treatment might be warranted.
Yeah, so exactly. So Jay raises the issue perfectly. The first question is, just because it's a seizure, do we have to treat? And the answer is not always yes. I mean, if all this man has had his finger twitch for 20 seconds, and it happens, it's happened a little more than once a month in the last 2 months, maybe you could sit tight and watch him and see what happens. Is it worth taking a pill every day for a finger twitching for 20 seconds, once or twice a month? I mean, how many of you would be willing to do that? I wish I had a poll up there. Would want to go on medicine every single day for finger twitching for 20 seconds or 40 seconds a month? And I probably wouldn't. The reason to treat him would be if his seizures got worse and convulsed. So I've been faced with this exact situation, and this patient who came to me a number of years ago, who actually had only been having it for about 6 weeks, not even 2 months, had a few attacks, and I had the discussion, and the decision was, I don't feel like taking another medicine, doc. Let's see how I do. And 3 days later, I swear, I got a call. He had another one, and it progressed, and he secondarily generalized, so he had a full convulsion. And then I felt badly, and he felt badly that he had a convulsion and fallen, and he banged his head and bruised himself. On the other hand, we knew putting him on medicine that he truly needed to take medication. I think it's a discussion to have, and some people may not want to take it. Odds are the way it is the way it will stay, but there is a significant chance that it could progress in time. So you have to be cautious. As far as the drugs, we see a lot of choice. There actually are official guidelines for drug of choice in elderly people. ILAE has this based on all the available evidence, and the 2 best drugs of choice in elderly actually that are recommended with class 1 evidence are Lamotrigine and gabapentin. Now, partly that's because great studies haven't been done for every drug. There are only a few studies of drugs in older people, and there's some data saying that levetiracetam is reasonably well tolerated as well. Some would say carbamazepine is less desirable because it's an enzyme inducer. So if it was an older person who's likely to be on multiple medicines, this fellow isn't, but if he were, carbamazepine may enhance the metabolism of some of the other drugs. If he's like many people and on a statin, most of the statins are metabolized by 3A4, and then you wind up with ineffective statin levels. So I don't have a poll question, but anybody know, if you're on an enzyme inducer like carbamazepine, or even a weaker inducer, which statin should you prescribe? There's only one that's safe, that's ideal. Anybody know the answer? It's the pearl of the day. The answer is rosuvastatin. Rosuvastatin will not be affected. So if they're on an enzyme inducer, rosuvastatin is what you want. But again, there's also data suggesting that in a significant number of people, maybe cholesterol levels go up a bit. On average, lipoprotein A is elevated, and that in formal calculations, the potential for cardiovascular disease, as indicated by cholesterol and lipoprotein, is increased significantly, maybe by 50%. CRP levels will also increase. So that's a reason to avoid an enzyme inducer. Also, he's an old guy. Enzyme inducers are associated, and carbamazepine in particular, associated with osteoporosis. I wouldn't do it for that reason alone. Divalproex, also not an enzyme inducer, but also associated with osteoporosis. Decent drug, but associated with osteoporosis. So let's move on to the next thing. Now, there have been a couple of studies. So this is one study published in 2005, so 15 years ago, by Jim Rowan. It was patients from the Veterans Administration hospitals, multi-center study, 593 randomized patients. They were randomized to gabapentin, a reasonable dose, 1,500 a day of lamotrigine, also in elderly, a reasonable dose, 150 a day, and carbamazepine, a good dose too, 600 milligrams a day. And then most dropouts from adverse effects occurred in the first 6 weeks, and then the lines are parallel. And you can see the highest retention rate, the top curve is in red, is lamotrigine. So lamotrigine was the drug that more people like to stay on than others, although you'll notice by the end of the year, about a third had dropped out. A third fell out, for, if not for side effects, which is what we saw early, for seizure recurrence. You can see gabapentin was next best tolerated. There wasn't much of a difference between the two. That was not statistically significant. And then carbamazepine at the bottom curve was tolerated less. It was significantly less tolerated. However, if you look at seizure freedom, which is the curve that's the best? The blue curve, carbamazepine. In fact, the people on lamotrigine and gabapentin were about the same, but they were more likely to relapse than people on carbamazepine. So yes, lamotrigine is better tolerated, but yes, it's probably not quite as good a drug, at least at that dose. Now, another study was done comparing lamotrigine with carbamazepine extended release. And again, these studies are from the early 2000s or late 90s, because that's when these drugs were out. And this is 184 patients randomly assigned to the two. And the retention rates were similar. It looks like they're, lamotrigine is a little higher on the top curve. This is time to all-cause withdrawal. And lamotrigine looks like it did a little better, but in fact, it's not statistically significant. So you can't say that they did a little better, but it wasn't statistically significant. The bottom line is one did not do better than the other. And with 184 patients, you need 300 or 500 or 800 patients to show a difference. It probably doesn't make that much difference. On the other hand, time to first seizure, you can see there is a difference here in the intent to treat. That's the ITT analysis. It was marginally significant superiority, time to first seizure for carbamazepine. And then if you look at per protocol, so people who actually followed the protocol and stayed on it, it was significantly better. So this again showed that in terms of answering the question, is carbamazepine more likely to hold seizures under control? The answer is yes. But for reasons I mentioned early, it's not a drug we like to go too early. And again, I think osteoporosis alone and then potential for pharmacokinetic interactions is sufficient. Now, there was another study published also in that same year by Martin Brody in Glasgow, looking at a randomized trial of Levetiracetam and carbamazepine in newly diagnosed epilepsy. And I don't know about your hospitals, but in mine, the L drug is the most popular by far. Even our emergency room doctors and our neurosurgeons, it's probably the only one they know at this point, Levetiracetam. In a randomized trial between that and Carbamazepine-ER, there was no difference. You can see the lines are identical, but you can see, at least if you're Scottish, only a little over half remain on the drug after a year. So the drugs are far from perfect. There are side effects or there are seizures. And you can see 73% were seizure-free for more than 6 months, but you could have one seizure in the middle and then still be, and then have a 6-month seizure-free interval, but you still had a relapse. So again, similar. So one can extrapolate if carbamazepine and lamotrigine has better tolerance. Carbamazepine is maybe a little better than lamotrigine in terms of retention. You can say that levetiracetam is pretty good for retention also. So what can we conclude? There are multiple drugs of similar efficacy. There are tolerability differences. More side effects in older people. You need to use lower doses. There's one study that says over age 60 or 65, I forget which, 100 milligrams of Lamotrigine is an effective dose. And then the drug interactions are important, so you want to choose drugs with minimal interactions. And I think that's where drugs like Levetiracetam or Lamotrigine a little less so, lacosamide more so, gabapentin more so, just don't have the interactions that are well tolerated. Given the prevalence of chronic pain in a lot of these populations, you could argue that gabapentin is also not a bad choice from that perspective. Most of us have a sense that it's not quite as effective in practice as some of the other drugs, but every time people do a study, it is as effective. So in the studies, it seems to work as well. And then older people have worse balance and worse cognitive problems, so that's why tolerability and balance is so important in these people. And a lot of older people have to get up out of bed in the middle of the night and use the bathroom. It's pretty common to have nocturia once or even twice for a lot of men and women. And they're at fall risk, so you really want to pay attention carefully, I think, to balance and talk to your patients. You know, maybe figure out what's safe in the house and pay careful attention to their balance and effect from drug. And you have to really monitor side effects carefully. It's no good to have somebody come back to you 3 months after you've started them on a drug and have them tell you, yes, ever since I started the drug, I've been unsteady. They need to know that if unsteadiness happens, they should contact you immediately because adjustment needs to be done. And lastly, monotherapy is ideal, lowest effective dose. And how do you know what the lowest effective dose is? By them not having a seizure. So you target low. If they have a seizure, you can always go up a little higher. Any questions or comments? So here's a question. Any data about Aptium in the elderly? Not that I'm aware of. I'm not aware of any elderly. I mean, older people were included in the Aptium studies. My recollection, they were allowed in the study up to age 75. But in terms of comparability of Aptium tolerability and retention rates in elderly versus other drugs, that study has not been done. It needs to be done. Okay, let's go to the next case. So this is a simple question for you. Look at the video, and please tell me if this is an epileptic or psychogenic seizure, and listen to her also, and watch her. The nurse is talking. She has a headache. That's why she's lying like that. She always has a headache. I hope you can hear. She says she's feeling tingling in her head.
Can you show me 2 fingers?
Nurse asked her to show 2 fingers. She continues to hold her head up. And she's not responding.
Can you tell me your name?
She's not answering to tell me your name.
What's your name? Can you point up to the ceiling?
Nurse asked her to point to the ceiling. She continues to hold her hands over her eyes. Nurse asked her, where are we? And that's her husband saying she's getting ready to go into a seizure.
Can you tell me your name?
Okay, and that was it. So, tell me what you think. Was this an epileptic seizure? Was it a psychogenic seizure? Was this syncope? Was it a paroxysmal dyskinesia? Offer your opinions quickly so we can move forward, and you're not going to get any more data than this, unfortunately. So 15 people have offered opinions thus far, 17 have, 18, a little bit more. Okay, I'm going to stop in 2 seconds, so get your vote in. 2, 1, stop. Okay, so 70% of people thought it was psychogenic and 35% thought it was epileptic according to our system. So 105% of you knew what she had. It's hard looking at this, right? It's really difficult to know what this is. She's still, she's quiet. Fortunately, if you look, she's in our monitoring unit. We have EEG running. Let me show you her EEG. So this is the first page when this was beginning. And ignore the box on the bottom. I feel like we're at the Wizard of Oz. Don't look at the writing. Just look at what you see. I have some arrows so you can see some things. And it looks like there's something happening in here. This is for right parasagittal, for left part parasagittal, AP direction, and then across the front F8 to F7. I'm going to go forward to the next page. You can see that. I've got more arrows there for you. All right, and then I'll go to the last page, and we're going to pull up another poll to ask what people think. What do you think this EEG showed? Was this a focal seizure, a generalized seizure? Was it normal sleep, or was there an artifact? We're getting votes. We'll go for a couple more seconds, and then we'll go back and look at it. Okay. Not as many people offered an opinion as before. So it looks like 15 out of 17 who voted for focal seizure. One said generalized and one said artifact. Okay, so let's go back. Right, so what we see at the start, this is right parasagittal, left parasagittal. It looks like we have rhythmic sharp waves at F4, and you can see it over here too. In the transverse at F4. If I go forward a page, we see these F4 sharp waves, and it's not really on the left, it's on the right. Focal, F4 sharp waves, then rhythmic theta activity, building up, occasionally a higher amplitude sharp wave, and we'll go back to that third page, and you can see a nice rhythmic buildup, and so whoops, I went accidentally clicked. At the end of the page, you can see there's some muscle activity, muscle artifact, and a rhythmic buildup. And it looks primarily on the right side, maybe a little spread to the left, but it's a nice phase reversal at F4. So this is a focal seizure. It's a focal right frontal seizure, and she's motionless. So we think about frontal lobe seizures as people having these hypermotor behavior, excessive movement, or tonic stiffening, or clonic activity. But in fact, you can have multiple behavior types with frontal lobe seizure. When she's quiet like this, you'd suspect orbital frontal origin with subtle movement. And and the scalp EEG is somewhat useful, but not enormously useful for localization. So it can pick up propagation or ultimately volume spread. So this could well be, and probably almost certainly is, an orbital frontal seizure in this case. I mean, there's no way this is at F4 premotor. You'd have tonic posturing and hypermotor behavior with this. She's quiet and still. So this really has the look of an orbital frontal seizure, or perhaps cingulate. Even, although with cingulate, ultimately it may spread to supplementary motor behavior. So just to keep in mind that not everybody who's kind of motionless and doesn't do very much with a seizure is, is temporal lobe. It can be frontal lobe also. Now, more of you thought that she had a psychogenic seizure than had an epileptic seizure when I just asked you based on the behavior. And the one thing I would say is you can't really know for sure, but if you think about your psychogenic seizure behavior list that you have, in whatever list you have and what you read about, that's not one of the characteristic psychogenic seizure behaviors, right? They have back arching, they'll have shaking. To just be motionless and hold their hands over their eyes is not a typical one. Is it possible? Yes. And maybe I should have had an answer there. I don't know. But at least it wasn't the typical psychogenic behavior. Okay. Any comments or questions before we move on? Anybody want to say anything? Or can I clarify why orbitofrontal? And I guess orbitofrontal, so Gabrielle asked that question. Why orbitofrontal? And I'd say because of the lack of obvious motor behavior. So again, if it's primary motor cortex, you'd expect clonic jerking. If it's immediately premotor, you expect tonic posturing, unilateral. If it were supplementary motor, and cingulate is next to that also, but it doesn't have to be. But if it were cingulate, then what you would see is supplementary motor bilateral posturing. If it were a little farther forward dorsolateral, you'd expect a hypermotor behavior with vigorous movement. So it was none of those. So what's the quiet spot in the frontal lobe or orbital cortex? I hope that answers. Does that answer your question, Gabriella? Any questions or comments? I guess so. Okay. Okay. Let's look at a couple of videos. I want you to tell me what this too. Anybody who attended the one a month ago, the fellow on the right's similar, but let's look at these two patients have something. There are brief durations of symptoms and look at the behavioral characteristics, okay? So watch this woman.
She just had another one. You can have people that.
That was it. Let's go back. Watch her again.
She just had another one. You can have people that.
Okay, that was hers. Let's look at his.
I'm Dr. Sperling. How do you do? How you doing? Nice to meet you. That again?
That was his. Let's go back and watch it again.
How you do? How you doing? Nice to meet you. That again?
Okay. Let's so what do you think this was? You've got several choices. Tic disorder, psychogenic, dystonic seizure, paroxysmal dyskinesia, or nothing abnormal. A lot of people are jumping in quickly, and almost all of you are right. Okay, we'll end the voting. We'll end it now. So you can see the results. 16 out of 21, so about 3/4 of you said dystonic seizure, and that's exactly, this is a classic faciobrachial dystonic seizure. Anybody want to say what this is associated with? What's the antibody? You can unmute and offer an opinion or type. Okay, somebody wrote, Lila Warden wrote, yep, a bunch of people. Right, so LGI1, the classic. Right, so this is classic, originally described as a potassium channel antibody and then really known to be LGI1 primarily. Classic faciobrachial dystonic seizure. It's very fast, it's brief, it's quick. Again, I'll just show you the video. You can watch her. Whoops, I forgot to start it from the beginning, though, it helps.
She just had another one. You can have people that.
Yeah, and you'll see it's written in the literature 3 to 5 seconds. In my experience, 3 seconds is a long one. And a lot of these people just have funny little facial movements. You'll see almost look like little tics. You could wonder about tic disorder, which is what two of you said, but this is paroxysmal, they're stereotyped, and they're not as frequent as tics usually. Psychogenic, unlikely. Somebody said paroxysmal dyskinesia. It's a thought, but again, this kind of behavior, faciobrachial is it. Okay, good. Case 4. 38-year-old woman, seizure started at age 25. Her seizures begin with an aura of a rising epigastric sensation. And she has this feeling for 15 to 20 seconds, and then she's got loss of awareness. If standing, she'll fall to the floor, actually, and it lasts for about a minute. So she's out of touch, she might fall, and she's had incomplete response to drugs, having seizures 3 to 6 times a year, of which she knows, although she'll be the first person to say that she doesn't always know when she's had a seizure. Sometimes when she's around other people, they tell her about them, and she hasn't realized that she's had it. If she falls, she knows she's had one, but she doesn't always fall to the floor. And she tries not to stand too much. She's not no neurological risk factors. She says her memory is fair. She has a special difficulty for remembering things that happened more recently. She says, if I saw something last week, I'd have much more trouble than remembering what happened 10 years ago. Her neurological examination is abnormal, and here is her EEG. So this is an interictal EEG. We will launch a poll, which is in the way. I'll move it to the side. So tell me what you think this EEG... what this EEG shows, okay? Oh, I have to, 1 second, I have to, I need to change it for another poll. So this is poll 6. I apologize, I didn't do it right. There, so poll 6, what do you think this abnormality is? And you've got a choice: left mid-temporal sharp waves, rhythmic, generalized rhythmic sharp waves, rhythmic mid-temporal theta of drowsiness, wicket rhythm, or left temporal seizure. Okay. So people are not coming in quite as fast as they were with the last one, but we're getting answers. Okay, so 3 or 4 more seconds and then we'll stop. 2, 1, we're going to end. Last chance to vote. Okay, good. So here's what people thought. I'll move it over so you should all be able to see what this is. So we have a quarter of you, 5 out of 21, said left mid-temporal sharp waves. Nobody thought it was generalized rhythmic. It's not generalized. We don't see it on the right. We just see this on the left. Rhythmic mid-temporal theta of drowsiness. Nobody thought. Wicket rhythm. 71% thought, and 2 people thought it was a left temporal seizure. So when you look at this, we see a rhythmical discharge, and we can count 1, 2, 3, 4 of these in half a second. That is a frequency of 8 hertz. So if it were 7 hertz or 6 hertz, we would call it rhythmic mid-temporal theta of drowsiness. Since it's at 8 hertz, we would call this rhythmic discharge a wicket rhythm. So this is a typical wicket rhythm, mid-temporal maximum. It can be misinterpreted as sharp waves. They look very spiky, but that's the classic appearance of a wicket rhythm, but they are not sharp waves. And again, the clue is you've got a nice rhythm. It's not that you've got a single thing and a big after going slow. There's an apparent little slow thing after this, but that's just the end of that rhythm. But you can see it in a rhythm. And you have to be especially careful when you see this in isolation. So you can have somebody who has a burst like this sometimes, and then on another occasion you might have a single one. But if that single one at a different spot looks just like the others, it's still part of the wicket rhythm. And a left temporal seizure, well, this burst is half a second long. It doesn't evolve. We can't call it a seizure. So that's a wicket rhythm. Okay. So what does that have to do with her epilepsy? Nothing. This is her MRI, and there is her interictal EEG on the right. Let's ask a question, and I have to now see what the question is. So the first question is, what does the MRI show? So here are your choices: normal, left mesial temporal sclerosis, right mesial temporal sclerosis, or bilateral mesial temporal sclerosis. You've only got one image. It's not a fair question. Don't blame me. I can't scroll through a whole MRI so easily. I don't want to spend the time. Okay, so 17 people have offered opinions. We have a few more to offer opinions, and then we're ready to go. Make up your minds. Okay, good. So almost all of you got it right. This shows right mesial temporal sclerosis. If you look at the amount of gray matter here on the right, it's vastly smaller than the left. It's probably atrophied by more than 50%. Again, ideally the criteria in MRI would be atrophy, loss of internal architecture, and increased signal. I don't have a T2 image for you to see the increased signal. This image is not the best for internal architecture, but it's clearly gone, and you've got a smooth hippocampus here. It's also a little malrotated on the right side. So this is classic right mesial temporal sclerosis. Okay. And then the interictal EEG, I don't think I have a poll for that one, but I think you've got very nice, obvious right anterior temporal sharp waves, or spikes actually. Here's a nice focal spike at F8. You see it here. Here it's coming out of us, a little bit of a sleep spindle in there on its own. So you've got so we have a history. If I can remind you of epigastric aura, loss of awareness, will fall on occasion, failed multiple medicines. That's nothing. Right temporal spikes, anterior temporal spikes, right mesial temporal sclerosis, epigastric aura. It's all consistent with a diagnosis, right? And then let's look at her seizure. I think I have to go forward a little bit. She's lying in bed. Now we're about 20 seconds in, and her eyes open. She looks around and she reaches and pushes the alarm button at this point. And she was lying in bed with eyes closed, opened her eyes and pushed the alarm button. Folding her hands. We're now waiting for our nurse to come in to respond to the alarm. Nurse asks if she's okay, and woman isn't saying anything.
Hello. Hi. How you doing?
She's rubbing her eyes just like the last patient.
Can you clap your hands 2 times for us?
Nurse asks her to clap. She's not speaking yet. But then she claps her hands.
Good. Can you tell us where you are?
Asks her where she is. Jefferson Hospital, she says. And then she says her name. And now she just, whoops, it went backwards. I didn't want it to do that. Let's go again here. Watch what she does with her hand, right? Go back. Watch what she does with her hand there. She rubs her nose. Okay, and then she said her name. So, what do we think about this? There's a lot to see when not much is happening. Which hemisphere do you think this seizure started? Right side, left side, or you cannot tell? And so far, everybody is spot on. Everyone who's answered is correct, except for one of you who isn't wrong. You just say you can't tell. You're still not wrong. So everybody is correct. Those who cannot tell are correct. They can't tell, and those who answer on one side are correct. Anybody else want to vote? Last chance. Okay. 16 out of 19 said right hemisphere, and 3 couldn't tell. Now, those of you who saw the EEG and the MRI, had a fair guess saying it's right hemisphere. You know she has right mesial temporal sclerosis and interictal right temporal spikes. But what were the behavioral features that said to you, this is right temporal? Somebody want to say? Okay, good. So Gitica says right nose wipe, ipsilateral right. So post-ictal, that was just at the end of the seizure. A nose wipe post-ictally is typically ipsilateral. So that pointed to the right side. Anything else? She can't talk, less likely left hemisphere. Well, can't talk could be either hemisphere, but actually, yeah, she can. She was able to say something. It wasn't clear to me, though, whether she started talking right when the seizure was over or not. But she did say one thing. She did say the hospital during it. And again, it was not only speech, because speech people can have automatic speech with either left or right temporal lobe seizures. But she was asked her where she was, and she said Jefferson Hospital. So, in fact, while the seizure was still on, she could actually answer appropriately. So I think you're right, Gabriella. The ability to speak and interact somewhat argues for non-dominant or right hemisphere. And again, automatism, somebody else says, with preserved consciousness, non-dominant, right? Yeah, so those things all argue for right hemisphere, non-dominant hemisphere in this case. The fact that we had some speech, she followed a command, she clapped, and then she had the post-ictal nose wipe. So this all argues for a right temporal focus. And one could easily say that the Ictal EEG shows exactly what you would dream it would here. This is with sphenoidal leads. You can see a beautiful big sharp wave in the right sphenoidal. Whoops, accidentally clicked. And then fast activity building up, a beautiful right anterior temporal, right sternodal, mesial temporal, or basal temporal ictal onset. So she's got a focal ictal onset. In fact, we found, I did an analysis, which I need to publish, 166 patients. If they have a strictly unilateral spike, the MRI shows unilateral mesial temporal sclerosis, same side with the spike, and the history is consistent with temporal lobe epilepsy, and her epigastric aura is a classic mesial temporal aura. The Ictal EEG never matters. Okay. So now, what therapy we're going to advise for her? What are we going to do? You have some choices. I have them on the slide and they're on that list. You know, try new medicine. She's already failed 4, we've been told. You could offer her a right anterior temporal lobectomy. You could offer a mesial temporal thermal ablation on the right side. You could offer her RNS. You could offer her deep brain stimulation, thalamic stimulator, or you could offer her vagus nerve stimulation. What are you going to do? We have 10 people have offered opinions so far. 17 have offered opinions. 18. 2 more seconds to make up your mind. That will have a major impact on this woman's life that you've thought about for a few seconds. 20. Okay. So let's share the results. And in fact, everybody was surgical. Yes. So she has been unresponsive, refractory to 4 medicines. The odds of her, having a sustained response to another medicine are forevermore incredibly low. And surgery is certainly reasonable to do. And half of the people said, well, actually not half, 9 said offer a right temporal lobectomy, and 11, so slightly more than half, said offer a right mesial temporal thermal ablation. Nobody offered RNS, nobody offered DBS or VNS. So the reason that I would argue that an anterior temporal lobectomy or thermal ablation are appropriate choices is that they have the potential for cure. RNS, DBS, and VNS are all palliative treatments, and people die from epilepsy, and she still won't be able to drive, which is an increased risk for injury and for death for that matter. So why not offer her something that has the potential to stop seizures completely, even if it's far from ideal? And which could you do? And some would say that the seizure-free rate for an anterior temporal lobectomy is higher than that of a mesial temporal thermal ablation. I would respond, maybe that's true. Show me. There's no published paper yet that actually says that that's the case. And people are getting better at it. I think both are good options. What you can say is that a mesial temporal thermal ablation is a 1-day hospitalization. People come into the hospital, for example, on Friday morning, go home on Saturday, and go back to work on Monday, and they have minimal discomfort. We don't even give them narcotics. They just take Tylenol for pain. An anterior temporal lobectomy is 3 days in the hospital, and you're out of work for 3 to 6 weeks, and it hurts a lot for certainly a few days, and often for a couple of weeks you have bad headaches. And if you do a thermal ablation and it doesn't work, you can always come back for a temporal lobectomy. If you have a temporal lobectomy, you could come back for a thermal ablation if the surgeon didn't get enough mesial structure, but you would consider the more benign thing first, perhaps. So I think it's a conversation to have with patients. If they're the sort of person that says, I don't really want to go to the operating room, do whatever you can the first time because I'm not coming back, or if you have a sense that your patient's unreliable, maybe I do the anterior temporal lobectomy, especially in the non-dominant hemisphere. Give it your best shot. You can take out more tissue. Maybe they do a little better. We don't know for a fact. On the other hand, if the notion of a 1-day hospitalization and basically no time off lost from work, or a couple of days lost from work at most, and minimal discomfort, and probably lower risk too. Nobody ever got a bone flap infection from a thermal ablation. The risk of meningitis and encephalitis is going to be lower. The risk of paralysis, of hemiplegia, is going to be lower as well. So it's a safer operation and a much better tolerated operation. It's reasonable to think about doing it first, provided the patient is aware to come back. We've had about half a dozen patients at Jefferson who we've had to bring back for additional procedures, either additional ablation or a temporal lobectomy. And I think when I last looked, we had 6 patients that we had done that to. 5 out of the 6 became seizure-free. And again, perhaps had the surgeon done a slightly different ablation, it might have been, we might not have had to bring them along. So what do we know? So there are 2 technologies, there are 2 devices. One is made by Monteris, one is the Visual Ace, which is now made by Medtronic. It's a monochromatic light. There's an aiming beam that the surgeon uses, and then the ablative beam is 980 nanometers, so it's outside the visible spectrum. There are 2 size, and this is for the Visual Ace system, there are 2 catheter tips. You can either have a 3mm one or a 10mm one for smaller or bigger lesions. The Monteris has a slightly larger tip also. and that tip can be angled a little bit, which may be an advantage if you're reaching around bends once you're inside and have to do something. The optical fiber is 12 meters long. It's a long fiber with a laser, and basically what the laser does is you can see the laser fiber inside, and then there's saline around it, a cooling catheter, so you're not actually heating this tip up. What you're doing is shooting light into the brain. The light heats up the brain and ablates it. So the tip never gets hot because you've got cooling saline going around it, and I think Monteris uses a cooling gas to go around it. So you're really delivering energy. This is done in the MR magnet. The surgeon can put the tip in the OR and then move the patient to the magnet, or you can have an MR in the OR. But the point is that they use a stereotactic frame, place it, and then you can, in the magnet, watch what happens. So this is what it looks like. You've got the laser applicator. The tip is sitting in the target area. Here's a sagittal view. Here's an axial view. You can see it sitting right in the anterior temporal lobe, mesial temporal lobe, where you want. In this case, this is the left temporal lobe surgery. And then this is a video, which I hope you can see, of the ablation. So the top is sort of calculated heat map. On the right is calculated lesion size. And then the bottom shows you developing heat on the left and developing lesion side on the right. So this is time showing blue, it's cold, it's getting hotter, 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 and then it heats up, and then they turn the light off. And usually it's on for a couple of minutes or so, 2 minutes, 2.5 minutes, to heat the brain suitably, ideally to denature protein. You don't want to heat it above 100 degrees. We don't like creating gas bubbles in the brain of water that is boiling. The surgeon puts that in, and then I'll go to the next slide. They're going to pull the catheter back a tiny bit and then do the whole thing again. So you can create a sausage-shaped lesion, and then the light is turned on again, creates a new circular lesion, which heats up gradually, and then after it's on for the calculated target size, it's over. And then what do you have at the end? This is the sausage-shaped lesion, which is basically, and they usually will do 3 separate ablations. There's one in the front, one in the middle, one in the back. So often 3 ablations, just pulling this back. You can see the sagittal and the axial. Very nice thing. I would point out this was taken immediately post-operatively, as soon as the ablation was finished. When you study these people 6 months later, the lesion's only about 2/3 of that size. So the immediate post-operative one overestimates. Somebody asked the question, does this ever cause gliosis or new seizure foci? I think that's always a possibility with epilepsy surgery. You would think if that were happening, causing a new seizure focus, it's not going to happen instantly, but the patient who's seizure-free and then maybe seizures come back in 6 months or a year or 2 or 5 or 10, you wonder, has that happened? Is there a new, has a new epileptic focus been generated by this? In general, it is thought that the odds of this happening are pretty small. We know from neurosurgery in people without seizures, and the best example is kids who have shunts, where you're creating a lesion by putting a shunt in for hydrocephalus, that the incidence of late epilepsy is low. It's not 0, but it's under 5%. So I think the vast majority of people who relapse probably relapse because we didn't ablate the right area or enough of the right area, rather than the ablation or any kind of surgery causing a new gliotic scar that's epileptic. The best study I know was published by Chen Wu, who was a surgeon at Jefferson. It came out in Epilepsia last summer, I believe, in June. It's a good study worth reading. It was a multi-center retrospective cohort study. Chen emailed colleagues in 10 other centers who had been doing this thermal ablation from December 2011, which was us, through August 2017 with later ones. 275 treated patients. He excluded 41 who had less than a year of follow-up, leaving 234 for assessment of seizure outcome. And then most amazingly, he got the DICOM images in 175 patients. So his neurosurgical friends around the country uploaded DICOM images from 175 patients so he could do an analysis of ablation volume and location. And what did we find about outcome in this series? Chen did it in 234 patients with at least, with sufficient outcome. And you can see in orange is patients with hippocampal sclerosis. Green are people who did not have hippocampal sclerosis but had mesial temporal ablation. So they may have had SEEG showing mesial temporal onset and had it done on that basis in total. And you can see that at 6 months, 12, 18, 24, and last follow-up, there's not a huge difference between the ones who had hippocampal sclerosis and those who didn't. but it looks like there's some, that the patients with normal MRIs don't do quite as well as those with. But you'll note with mesial temporal sclerosis, it's not bad. It's in the neighborhood of 60% are seizure-free. A little higher earlier on. And then what Chen did, which was especially interesting, was he looked at the ablation areas between the people who did well and the people who didn't do well. And I wish his figure had thicker green and red lines, but I hope you can see it, except for those of you who are looking at this on a phone. But this in red is the typical ablation for patients with persistent seizure out here. And then in green are the ablations in people who were seizure-free after surgery. Whoops. All right. And you can see that the patients who had a favorable outcome, that is seizure-free, tended to have more anterior and more medial ablations. You can see it in the axial here, in the coronal cut. Again, you can see the more medial, and here you can see getting perirhinal cortex into parahippocampal gyrus, whereas the unsuccessful ones were more lateral. And you can see in the sagittal, again, it shows nicely that the good ablations, the people who were seizure-free, were more anterior, the ones were farther back. So there's it clearly matters where you ablated in these patients. And again, thinking about what's the seizure-free rate from this procedure, it's very crude and I think inaccurate to think, well, people don't do as well as this or that, or it's for the kind of ablation what you expect, because the same thing applies to an anterior temporal lobectomy. Some surgeons do a much better job with mesial excision than others. Some take out more, some take out less. We've seen some patients where the surgeon omitted the hippocampus entirely, just didn't get to it, where they leave a lot of other things anteriorly that you might want to take. So, in fact, this would leave us to believe that, if we just look at this group, you would have a much higher seizure-free rate. And as our surgeons learn more and can alter targeting, we would hope that the seizure-free rate gets even higher. So if the world of mesial temporal ablations is not perfect yet, it should get better later. We would hope that that's the case. I had one more case that I'm not going to discuss because we only have a few minutes, and I'd rather end early than late. And we can always do that another time. That was a discussion of rescue therapy. So for someone like this, to finish this case up, and then we'll open up for questions and comments, it's worth considering. You have to have that discussion. And again, looking at the world of results, if you look at anterior temporal lobectomy, you'll find seizure-free rates are in the neighborhood of published studies 59 to 65, 66%. You'll see some individual uncontrolled series where people report better rates, but the prospective studies, anterior temporal lobectomy for mesial temporal sclerosis at best in 70%, 75%, and some series are worse. They're as low as 59% or 60%. And it may be, you saw we were in the neighborhood of 60 to 65% in these cases, and in cases with mesial temporal sclerosis, it was about 65% seizure-free. And I think altering targeting, it will be feasible to get that seizure-free rate up a little higher. Again, arguably in the non-dominant hemisphere, you have less of a compulsion to do this other than patient comfort and lower risk. For a dominant hemisphere, what are the advantages? And what's been shown is that memory is not clearly better after this than a temporal lobectomy. There are a couple of studies saying that memory is not quite as badly affected, and other studies saying that it is. And I think with a good ablation, you'll probably affect memory equally badly. What will make a difference, though, is language after surgery. And there are a few studies showing that ability to name and drain, Dan Drain at Emory University has shown that naming is better after this than in a full temporal lobectomy, although not for the Boston naming test. He's shown it for famous names. So showing pictures of famous people, recognizing that, which is still an aspect of naming, and other aspects of language may be better preserved. So taking out less tissue, you have less loss of function, particularly with regard to language as expected. I'm not convinced that there's less loss of memory. Maybe there would be, because we know the middle temporal gyrus plays a role in memory as well, in encoding and in retrieval. And by sparing middle temporal gyrus, maybe you have a little bit of advantage there as well. It's possible, but good studies have yet to be done in that. So questions and comments before we finish? Everybody's very quiet. Okay, well, somebody wrote, Khalil, you wrote doctor, but nothing more. Do you have a question or a comment to make? What is this? Okay. Okay, oh, good. So we're going to say, so what is the specificity of post-ictal nose wiping? I don't know the answer to that. What's been published is that it's highly reliable. I don't know how often it gives you a false positive. I think what's been published has been small, but it's not like they have hundreds of patients with post-ictal nose wiping. The numbers are relatively small. Okay, and you're welcome, Jay, for your comment. So if there are no other comments or questions, I think we'll end. Thank you all for attending. I hope it was useful. And the American Epilepsy Society is doing more educational programs. Our thought was in the Education Council, which I'm a member of, is that in this time, a lot of monitoring units have been shut down, closed, volumes are down, the experience is lower, and it would be nice to have exposure to more cases, more case discussions, and also have a chance to hear faculty from other places you might not be exposed to get a sense from that. So I hope it was helpful for everyone, and we look forward to seeing you again at more AES presentations. Goodbye.